Hi everyone, welcome to this video lecture on intravenous fluids. My name is Dr. Ashley Miller and I'm a consultant in intensive care medicine. In this talk I'm going to briefly go through some of the historical background to IV fluid prescribing. We'll then spend a bit of time on physiology before briefly outlining some evidence. I'll close with a summary of what I think we should actually be doing for our patients with some take-home messages. On the last slide will be a QR code that you can point your phone at. This will link you to a fluid guideline that contains much of the information in this lecture. So why am I talking to you about this? Well, fluid prescribing is a massive problem nationally. Audit data shows poor general knowledge of intravenous fluids and very poor prescribing practice. A NICE review on this, first written in 2013, identified that at least 1 in 5 patients come to harm from IV fluid mismanagement. Now, humans are pretty robust, so there will be many examples of people having potentially harmful fluid management without ever actually coming to harm. Much of the time we're getting away with it. Unfortunately, at least 20% of the time we aren't. Now, I'm particularly passionate about this topic because of the patients I've seen admitted to intensive care as a direct consequence of fluid mismanagement. And this has happened in every hospital I've worked in, and colleagues of mine up and down the country tell me it happens in their hospitals too. There is nothing worse than a patient who becomes critically unwell from being in hospital when it would have been safer if they had stayed at home. The use of intravenous fluid therapy can be traced back to cholera outbreaks as early as the 1830s. Cholera, of course, causes the loss of large volumes of extracellular fluid from diarrhea, causing hypovolemic shock. And resuscitation with fluid can be life-saving in such situations. IV fluids began to be used during anaesthesia in the 1880s, and by the mid-20th century, doctors were advocating large volume fluid administration for critically ill patients and those undergoing major surgery, based on experience of treating injured soldiers in the Korean War. It was the work of a doctor named Shoemaker and his various colleagues around 30 years ago that really popularised the concept of maximising oxygen delivery with large volumes of IV fluid. It had been discovered that critical illness results in increased metabolic demand, increased oxygen requirements, reduced oxygen delivery, and reduced oxygen utilisation and extraction ratio in the tissues, the net result being tissue hypoxia. It seemed plausible that maximising oxygen delivery would lead to better outcomes, and Shoemaker and colleagues published a few studies seeming to back this up. Now, these results have never been replicated, but the global intensive care community based on this work became convinced that sick patients needed optimization of oxygen delivery with aggressive fluid resuscitation to prevent or ameliorate organ dysfunction, and we've spent the last 30 years teaching clinicians in our own and other specialities that this is how sick patients should be managed. We've taught it on alert courses, CRISP courses, life support courses, ATLS courses, etc., etc. And the idea has filtered through to permeate all specialities, and until recently has been virtually unquestioned. This concept has even permeated international guidelines, like the Surviving Sepsis campaign, which advocates an initial 30 mL per kilo bolus of so-called resuscitation fluid, which even the authors admit has no good evidence base. A famous, or perhaps now infamous, study by Rivers in 2001 on the early goal-directed management of sepsis seemed the proof that everyone had been looking for, that this practice was best for our patients. Now, we'll come on to this trial later, but for now, just note that both the intervention and control groups received about 14 litres of crystalloids in the first 72 hours of their illness, showing just how normal this practice of large volume fluid resuscitation had become. When I was training in intensive care, we spent much of our time with fancy bits of kit, like pulmonary artery catheters and then later non-invasive cardiac output monitors, to chase oxygen delivery and fluids and drugs. This made us feel like we were at the cutting edge of the management of sick patients. Unfortunately, it turns out we were wrong, and we'll see why that is the case shortly. Now, another area that may have helped lead to bad IV fluid practice is perioperative medicine. A few case reports of hyponatremia in elderly patients given too much 5% glucose post-operatively made anaesthetists nervous about prescribing anything but Hartmann's. If you prescribe your patient a couple of bags of Hartmann's post-op, you can be fairly confident their sodium levels will be okay the next day. This practice seems to have filtered through to general prescribing on the wards. I think when junior doctors see Hartmann's prescribed post-op by an anaesthetist, they think they need to copy the prescription. The more Hartmann's is written on drug charts, the more it gets used. This then filters through to prescribing fluids for those who are simply nil by mouth. Now, poor fluid prescribing isn't all the fault of intensive care doctors and anaesthetists. Much of it is just lack of knowledge, or dare I say it sometimes, laziness. When the nurse hands you a drug card, it's much easier to copy the last bag of fluid that was prescribed than find out what is wrong with the patient, what their blood results are, and what their fluid balance is. So we've ended up in this situation where all sick patients, post-operative patients, and many nil by mouth patients all get given lots of very salty IV water. And by this I mean 0.9% sodium chloride or compound sodium lactate, also known as Hartmann's. So let's have a look at some physiology. Why do patients actually need fluid? Well, there are two reasons. One is for resuscitation, and the other is for hydration in patients who are nil by mouth, what we call maintenance fluid. So let's start by looking at resuscitation fluid. Here we have a representation of our circulation. Blood flow on the arterial side of the circulation is driven by the pumping action of the heart. The left ventricle pumps blood into the high resistance arterial system, and as long as this pressure is high enough, blood flows down a pressure gradient to the organs. However, blood flow back to the heart from the veins, which we call venous return, is not the result of the heart's pumping action, which we will see shortly. Our veins contain around 2/3 of our blood volume, and particularly our splanchnic veins are in effect a capacitance system like the tank in the picture. So, here are our splanchnic veins represented by our tank. Venous return is dependent on the pressure gradient from the veins to the right atrium. So how is this pressure gradient generated? Well, a certain amount of blood can fill the veins without exerting any pressure on their walls. Once a certain threshold is passed, any further increase in venous volume will exert a pressure on the walls of the veins, counteracted by their elastic recoil. This generates the pressure in the veins. It may help you to think about inflating a tyre to conceptualize this. Now, any blood in the veins that exerts pressure on their walls is like the volume in the tank above the outlet. This is called stressed volume. The more volume there is above the outlet, the greater the pressure, and therefore the greater the flow out of the tank. And the greater the venous return, the greater the cardiac output, as by definition, the two must be the same. The amount of blood coming out of the heart must be the same as the amount of blood coming into the heart. Now, the amount of blood in the veins not exerting a pressure effect is akin to the volume in the tank below the outlet. This does not contribute to flow out of the tank, and this is called unstressed volume. Let's have a look at what happens if we lose blood from the tank. In other words, if we become hypovolemic. Stressed volume falls, venous return reduces, and cardiac output falls. If this happens, our sympathetic nervous system is activated. Our splanchnic veins are heavily innervated with alpha receptors, which means they can constrict and dilate very easily. Activation of our sympathetic nervous system causes stimulation of these alpha receptors, which causes venoconstriction. In effect, the walls of the tank constrict, converting unstressed volume to stressed volume. So even though there is less blood in the system overall, the pressure gradient for venous return is maintained, and cardiac output and blood pressure are relatively preserved. Now there does of course come a point when the veins can't constrict anymore. If any more blood is lost, the sympathetic nervous system can't compensate any further, and cardiac output and blood pressure will fall. This is why we always need to be very wary about patients who may be hypovolemic, who appear to have a reasonable blood pressure. It may just be about to crash. Now, hypovolemia only has two causes. One is bleeding, and the other is the loss of extracellular fluid. Now, bleeding is usually pretty obvious. The context is likely to be something like trauma, a post-operative patient, or a patient having a GI bleed. Stopping the bleeding is the priority, and judicious use of fluid and blood to support the circulation will buy time and restore circulating volume. And don't forget to be aware of sympathetic compensation. The other cause of hypovolemia is ECF loss, extracellular fluid loss. This means losing water and sodium. And usually it's from vomiting or diarrhea, but it could be from excessive sweating, such as having a high fever, or if you're a professional fighter, from extreme weight cutting. The salty water we lose has varying amounts of sodium in it. Gastric fluid, so vomit, has about half the sodium concentration of plasma, whereas bowel losses often have a similar sodium concentration to plasma. And you can see in the slide here the exact concentrations from each location in the GI tract. So how do we diagnose extracellular fluid loss? There's no blood on the floor like we have with bleeding patients. The most important thing by far is the history. There's also signs. So sympathetic signs include tachycardia, oliguria, poor peripheral perfusion, anxiety, and also low blood pressure if it's severe enough. And these are all reasonably sensitive signs, but they aren't specific. There are many other causes for these that are not hypovolemia. Blood tests will show fairly normal sodium levels because the patient is losing sodium and water, so the overall concentration will be the same. Because of the fluid loss, hemoglobin and hematocrit levels will increase as the blood becomes more concentrated, although there may be other reasons for this not to manifest. Because the history is such a giveaway, that combined with these other signs make the diagnosis fairly easy. You can also deduce that it's not that common in hospital patients. Patients might present to hospital with ECF loss, but the only reasons for it happening in hospital are things like ongoing diarrhea, vomiting, a high output stoma, or bowel obstruction where fluid can pool in the gut. It's worth mentioning dehydration here. This is often confused with ECF loss. Strictly speaking, pure dehydration is water deficiency, either from reduced intake or increased losses, and it causes hypertonicity. The blood becomes more concentrated. Because sodium isn't lost, the diagnosis is even easier than ECF losses. There'll be a history of reduced water intake or increased loss. Sodium, urea, and hemoglobin will all be high. Remember that hemoglobin is often reduced in hospital patients for a multitude of reasons, so the real giveaway is a high sodium. All the patients you see in hospital with a high sodium are water deficient. This is completely unacceptable in hospital. The patient just needs some water. Now, often, of course, extracellular fluid loss and dehydration are combined. A vomiting patient, for example, will be unable to keep water down and so will become water deficient and salty water deficient. The treatment of hypovolemia from ECF loss and the treatment for dehydration is a question of common sense. Just replace what has been lost. You can calculate a rough deficit from the history, and then if sodium is high, give some water. If the sodium is normal and the patient is hypovolemic, give them some compound sodium lactate. And of course, GI losses are likely to need compound sodium lactate as replacement fluid as they are losing salty water from the GI tract. So if we go back to our hypovolemic tank with compensatory vasoconstriction, we can see that if we fix the reason for the blood or ECF loss and put some fluid back in the tank, the system will go back to normal. This would be an example of judicious use of IV fluid. What about inflammatory states like sepsis and pancreatitis? Hypovolemia from fluid loss is pretty easy to understand, but there are different concepts to learn about here. Let's see what happens to our cardiovascular system if we become vasodilated. This is the equivalent of the tank increasing in size. As the overall volume of blood in the tank is the same, the stressed portion falls, causing venous return and cardiac output to fall. One option would be to fill the tank with more fluid, but there are problems with this. Firstly, it doesn't treat the cause. Secondly, it's not very efficient. You'd have to put quite a lot of volume in to make a significant difference to how much comes out. Imagine your bath at home emptying out of the plug hole. Turning the tap on makes very little difference to the height of the water in the bath, as it's such a big volume. Thirdly, because of the vasodilatation, the veins lose their tone. If you put more volume in them, they'll just dilate more, making little difference to the volume that is stressed. Fourthly, once the disease resolves, the patient will be significantly fluid overloaded. This is when we need to use vasopressor drugs to reduce the size of the tank and convert unstressed volume back to stressed volume to increase venous return and cardiac output. Here's a practical example to illustrate how me compressing the bottle converts unstressed volume to stressed volume, which increases the flow out of the bottle. So me squeezing the bottle here is just like sympathetic activation or using vasopressor drugs to constrict the veins and then increase venous return from increasing stressed venous volume. Now I can hear you asking yourselves, what about fluids leaking into tissues causing hypovolemia? As we're often taught about with sepsis. Now there's amazingly little evidence for this. You'd have to measure a patient's circulating blood volume before and after becoming unwell, and this is both difficult and prone to inaccuracies that invalidate any conclusions. There is a rare condition of unknown cause called Clarkson's disease, and that causes massive capillary leak with consequent hypovolemia. Treating it is apparently a nightmare, as any fluid you put back in leaks straight back out. One of the main clinical features of this disease is edema. Patients present to the hospital with hypovolemia and edema. Now think back to all the hypotensive patients you've seen with sepsis or pancreatitis. How many of them presented with edema? The answer is none. Many of them become edematous after treatment in hospital with IV fluid, but none of them were like that in the emergency department. It is true that capillaries in sepsis become damaged and more prone to leak, but crucially this only seems to happen at high capillary pressures. Fluid won't leak out at lower normal pressures, but will leak out if you raise the capillary pressure with IV fluid. And we're going to see next what happens when capillary and venous pressures become raised. What happens if we give too much fluid? Firstly, we can't cause hypervolemia with pure water. If you drink a litre of water, you'll pee it out really quickly. This is because osmoreceptors in our hypothalamus detect very small changes in osmolality and inhibit antidiuretic hormone, so we excrete any excess water. Weirdly, water is in fact the best diuretic, assuming normal renal function. It's a different story, however, with salty water. Fluids like saline and Hartmann's are virtually isotonic with plasma. This means osmoreceptors are not activated. Our volume receptors are much less sensitive than our osmoreceptors, and it takes a long time to excrete this excess fluid. Some of this excess fluid will stay in the vessels, and some of it will go into the tissues. So if we do this to our patients by giving them salty IV fluid, they end up looking like this, except not so happy looking. Other than aesthetics though, does this edema actually matter? We've looked earlier at the cardiovascular system, but we've not yet focused in on organ perfusion, so let's do that now. We've seen already in our diagram that the heart drives blood flow through the arterial system. For blood to flow to a specific organ, the mean pressure in the main arteries just has to be higher than a certain minimum pressure. The arterioles in the individual organs, represented in the diagram by the tap, then auto-regulate their size to maintain a constant perfusion pressure. They can auto-regulate effectively at a wide range of blood pressures. The kidney, for example, maintains constant flow at mean blood pressures between 60 and 180. So as long as mean arterial pressure is above around 60, there is little you can do to improve organ blood flow from the arterial side of the circulation. Let's have a closer look at organ blood flow. Flow, of course, occurs down a pressure gradient. The pressure gradient in any organ will be arterial pressure minus the compartment pressure of the organ and the venous pressure it empties into. So organ blood flow is driven by arterial pressure, but opposed by the compartment pressure in the organ and the venous pressure. And we've already seen that there is little we can do to improve the flow from the arterial side, as long as the blood pressure is not very low, and so compartment pressure and venous pressures become extremely important. So what effect does IV fluid have on this? If there's hypovolemia and a significantly low blood pressure, then IV fluid will improve arterial and thus organ blood flow. But if there is not hypovolemia, IV fluid will increase venous pressures, it will leak into the tissues causing edema and increased compartment pressures, because it's not just the skin that becomes edematous, it's the organs themselves as well. And this will be exacerbated by the fact that aggressive fluid therapy actually damages the glycocalyx lining the vessel walls, causing even more fluid leak into the tissues. And not only this, but fluid overload causes the heart to fail too. So what are the overall consequences of this? Well, you get reduced cardiac output, increased venous and compartment pressures, vessel wall damage, and these all lead to reduced organ perfusion. This in turn leads to organ injury, increased length of stay, and possibly death. It's worth noting that the kidneys are particularly sensitive to these effects. Just think for a minute about all the patients with acute kidney injury that you've given fluids to. Most of the time you have just been making this worse and reducing the perfusion of the kidneys. Now here's a slide of all the bad things that happen in each organ system with fluid overload. I won't go through them all, but feel free to pause the video to read them in more detail. Here's a quick clinical case for you. This is an echo of a post-laparotomy patient 4 days down the line from their operation on 40 mils of noradrenaline, which is a lot. They're 11 litres fluid positive, edematous, on renal replacement therapy, so like a dialysis machine, with no fluid removal dialed in, and a low cardiac output on the cardiac output monitor. You can see that the right side of the heart, which are the chambers at the top of each image, are significantly dilated. Usually the right heart is smaller than the left. Here you can clearly see the sizes have been reversed. You can also see that the left ventricle is being squashed. This is because the right heart dilates quickly and easily with fluid overload. And the uncompliant pericardium lining the heart means that when the right heart dilates, filling of the left heart is impaired as it gets squashed and cardiac output falls. So with this patient, I took 9 litres of fluid off by filtration over 48 hours. This allowed the left ventricle to fill better and reduced the venous and compartment pressures in the kidney and other organs. By this point, vasopressors had been weaned off completely and the patient started to pass urine. Let's look at some actual evidence. So considerably less than half of shocked septic patients increase their stroke volume, which is the amount of blood being pumped out of the heart, with fluids. In a healthy person, only 15% of a fluid bolus remains in the blood vessels 3 hours later, and stroke volume returns to baseline in half an hour. So if you give a litre of Hartmann's or saline to a healthy patient, only 150 mils of that litre will stay in their blood vessels. The rest will go into the tissues. In a patient that's septic, only 50 mils of that 1 litre will still be in their circulation an hour after you give it. Even in fluid-responsive patients, so those that have increased their stroke volume with a fluid bolus, this will go back to baseline in 1 hour and their urine output doesn't increase. So an hour later, your patient is no better from a hemodynamic perspective, but has a litre, or however much you've given, of excess fluid in their system. 2/3 of septic patients also have heart failure caused by the sepsis, making them even more prone to harm from fluid. Let's look at the single largest study in this area, the FEAST trial. This randomised 3,000 shocked septic children in Africa to receive fluid boluses or maintenance fluids only. And what this trial showed was that there was increased mortality in the fluid bolus group. So those children who were fluid resuscitated compared to those children who just got maintenance fluid died more. And this was a massive shock to the critical care community. Because of this, many people couldn't accept it and looked for ways to criticise it, such as the high incidence of malaria and anemia in the patients. So to respond to these criticisms, the data was reanalysed, and this showed excess mortality in all subgroups. There was no difference if the patients had malaria or not, and no difference if they were fluid responders or not. There was also 3 large multi-centres done to try and replicate the results of the RIVERS study on early goal-directed therapy that I mentioned earlier. This slide shows these trials, along with the RIVERS trial, evaluating early goal-directed therapy over the 14 years they were conducted over. And these are interesting for a few reasons. Number one, clinicians can be seen to be using less IV fluid over that time in the 15 years these studies were performed over. It's also interesting to note that the decrease in fluids used over this time mirrors the decrease in mortality over this time. Also, central venous pressure and the amount of fluid administered in the first 6 hours were clearly linked, showing how venous pressures increased with fluid administration. Most importantly, the PROCESS, ARISE and PROMISE trials proved conclusively that treatments targeted at increasing stroke volume are of no benefit. We could finally put Shoemaker's theories to bed. What other evidence do we have? Here are just a few examples. So in fluid overloaded patients, we have increased morbidity and mortality, with fluid overload being an independent predictor from a systematic review. There are multiple examples of a high CVP being associated with kidney injury. We've got increased mortality in patients with acute kidney injury, prolonged recovery with acute lung injury, increased mortality in septic shock patients, increased morbidity in colorectal surgery, increased amounts of intra-abdominal hypertension, all linked with hypovolemia, fluid overload. So hopefully all this evidence convinces you that fluid overload is really bad for our patients. Now you'll be pleased to know we haven't got far to go. We've finished resuscitation fluid. But let's have a brief look at maintenance fluid. So how much fluid and electrolytes do humans actually need? Well, first of all, we need some water, and we need 25 to 30 mils per kilo every day, or that's around 1.2 mils per kilo per hour, or if you're a 70 kilo person, around 85 mils an hour, or 2 litres a day. Remember it however you want. We also need some electrolytes as well as water. We need 1 millimole per kilogram per day of sodium, potassium and chloride. And we also need between 50 and 100 grams of glucose every 24 hours to prevent us getting ketosis. It doesn't, of course, provide all our nutritional needs, but will prevent ketosis. Now let's talk for a minute about sodium. If you think in evolutionary terms, we've adapted to hold on to sodium very well. This would have been in limited supply to our ancestors, and holding on to it in times of stress or blood loss helps maintain vascular volume. Excess sodium is a modern phenomenon humans have not adapted to deal with. We're very good at holding on to sodium, we're very bad at getting rid of it. Water is always retained with salt in the body, so sodium and fluid overload go hand in hand. Finally, it's worth noting that many drugs like antibiotics also have lots of sodium in them. Now, how many bags of crisps do you think you would need to eat to get the same amount of salt as you'd be getting from 1 litre of 0.9% sodium chloride? And I'm talking about the big individual bags you get, not the slightly smaller ones you get in multi-packs. So 1 litre of saline has the same amount of salt in it as 22 bags of crisps. Just 1 litre. So let's have a look at what fluids we have available for prescribing and see which ones we should be using. So here's a table of the most commonly prescribed fluids that we use. We've got 0.9% sodium chloride, often called saline. We've got compound sodium lactate, which is often called Hartmann's. We've got glucose 4% with sodium chloride 0.18%. That's often called dextrosaline. And then we've got 5% glucose, which is often just called dextrose. Now you can see in the table how much sodium, chloride, potassium and glucose each of those fluids have. And if you remember how much sodium, chloride and potassium and glucose people actually need each day, you can work out from this table what fluids you should be prescribing. And we can make that a bit clearer with this table here. So saline has way too much sodium and chloride in. 1 litre of sodium chloride has over twice the amount of sodium that you need in a day. So if you give somebody their 2-litre water requirement and you're doing that with saline, then they're getting way too much sodium. Compound sodium lactate has slightly less sodium in than saline, but it still has far too much. On the other hand, we've got this fluid, glucose 4%, sodium chloride 0.18%, dextrose saline, that's perfect. If you give a patient 2 litres of that, they get their water requirement for the day, they get their sodium requirement for the day, and you can add 20 to 40 millimoles of potassium into each bag, and then they'll get just the amount of potassium that they need. You can also prescribe 5% glucose, and that's good if sodium is high. You do need to be aware of hyponatremia though. Patients do need some sodium if it's not already high. So here is our maintenance fluid of choice. Easy peasy. As we're coming to the end now, I want to share with you just a few of the prescriptions of patients that have come to the intensive care unit because of fluid overload. This was a post-operative patient who was prescribed what you can see here on the chart for maintenance fluid post-operatively. So Hartmann's, saline, 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 saline. All over a couple of days. That's 1,779 millimoles of sodium, which is 102 grams of salt, which is equivalent to 258 bags of crisps. Very difficult for patients to get rid of that amount of sodium and water. This is my absolute favourite drug card of a pancreatitis patient. Given saline, saline, Hartmann, saline, saline, Hartmann's, Hartmann, saline, saline, saline. And there's the GTN infusion for the pulmonary edema and the amiodarone for the fast AF. Iatrogenic critical illness. Here's another patient with pancreatitis, referred to us because of ARDS, secondary to pancreatitis. And of course, despite what the books say, ARDS is not caused by pancreatitis. It's simply iatrogenic pulmonary edema because of fluid overload. Here's another pancreatitis patient. Lots of Hartmann's, a bit of saline in this case. Here's a patient with hematological malignancy who also had a pneumonia, referred to us with ARDS. Again, iatrogenic from fluid overload. All these patients who come to us with fluid overload, with respiratory failure, with kidney failure, we give them diuretics or we take the fluid out by filtration. They get better and we send them back to the ward. So what are our take-home messages? So IV fluids can be life-saving. If you're genuinely hypovolemic, they can save your life, but they can also kill you. Maintenance fluid. Let patients drink oral fluids, if at all possible. If not, then they need 1.2 mils per kilo of dextrose saline with some potassium in each day. Compound sodium lactate and 0.9% saline are not maintenance fluids. They have way too much sodium in and they will cause harm to your patients. Now, there may be specific reasons for going off plan, but these should be able to be justified though, and they are dealt with in the full fluid guideline that you'll have a link to. Resuscitation. First of all, treat the cause. If the patient is bleeding, stop it, and you can judiciously support the circulation with compound sodium lactate or a blood transfusion. If hypovolemia is due to extracellular fluid loss, then treat with compound sodium lactate. And once you've given a maximum of 2 litres, refer the patient to the intensive care unit. If a patient has sepsis or pancreatitis, you must treat any associated ECF deficit or dehydration. So if a patient's been unwell for a few days, a patient's had associated diarrhea and vomiting, that volume will need replacing. But again, after a maximum of 2 litres, they need referring to the intensive care team. Now here's an example of a new drug card that's been designed, and it tells you on the fluid prescription chart when and how and why to prescribe fluids. So there's no excuse for doing it wrong. Here's the QR code that will link you to the full fluid guideline. If you point your phone camera at this, it should automatically link you to the website with the documents on, which you can download and read at your leisure. So thank you very much, and go and put this into practice.